Good morning, Dr. Poteat.
Good morning. How are you?
Doing well.
Good. You are the star of the show. I have you highlighted on my screen.
All right, Dr. Poteat, Dr. Schneider, are we ready to get started? Okay, and I think Kimberly McMillan has already started our recording. So we're very excited to welcome everyone to Grand Rounds today. And I have the pleasure of handing the mic over to Dr. Jason Schneider to do our introductions. But we are very excited to have our annual William T. Branch Grand Rounds lecture. And Jason, I will hand it over to you.
Thank you, Dr. Law. It gives me great pleasure to introduce my friend, colleague, and co-conspirator, Dr. Tonia Poteat, for this Grand Rounds presentation. Tonia is a professor in the Duke University School of Nursing and co-director of the Duke Sexual and Gender Minority Wellness Program, also the associate director of the Duke Center for AIDS Research Developmental Core. Her research, teaching, and clinical practice focus on LGBTQ health and HIV, with particular attention to the health of transgender and gender diverse communities. She directs the RISE Lab, where her community-engaged research attends to the role of intersectional structural stigma in driving health inequities and seeks to identify strategies to advance health justice. She is a leader in research and care with transgender persons and an HIV specialist certified by the American Academy of HIV Medicine. Tonia has a strong Emory connection. She is an alum of our PA program, and she has 30 years of experience providing medical care for transgender adults and people living with HIV. She is an associate editor for the Journal of LGBT Health and has served on consensus panels for the National Academies of Science, Engineering, and Medicine several times, actually. And she is deeply committed to community-engaged research with actionable findings. And we are colleagues in at least two cohort studies now examining health outcomes for transgender women and trans feminine people. And should be noted that Dr. Poteat will be giving the William T. Branch Innovations in Primary Care invited lecture tomorrow evening at the School of Medicine, and honored to have Dr. Branch join us for Grand Rounds today as well. So Dr. Poteat, delighted that you've taken time out of your busy travel schedule, I know, to be here with us, and I'm so excited you're presenting on this topic for us today.
Thank you so much, Jason, for that really kind introduction. And Jason and I have collaborated on multiple studies together, so it was really a delight to have you introduce me. And there are many friends at Emory that I see here, so thank you all for showing up. I'd just like to start with the land acknowledgement. I think Emory has done actually a really nice job on their website, so I have the links at the bottom on the fact that we are gathering on the ancestral grounds of the Muskogee Nation, and also Emory's role in enslavement and how it helped to build the university. So please check out those links below. I also want to share my disclosures that I've conducted research supported by pharmaceutical companies, and that the studies that I'm going to talk about today are supported by the National Institutes of Health, as well as the Duke Center for AIDS Research. So what I'd like to do for the next 45 minutes until we get to have a discussion is to start with thinking about the implications of the clinical algorithms that we commonly use in practice for assessing the cardiovascular disease risk with transgender patients. Describe allostatic load, what it means, how we measure it, and then a role it might play in the cardiovascular health of transgender women. I've organized my talk around the American Heart Association scientific statement on assessing and addressing cardiovascular health in people who are transgender and gender diverse that was published in 2021. And I'm going to start with the assessing part, and that's when we're going to talk about the algorithms for assessing cardiovascular disease risk. So hopefully most folks are familiar with this. It's the pooled cohort equation that is built on the sort of Goff paper that came out in 2013, and then it was revised in 2018 and updated. And it provides an estimate of the risk of atherosclerotic cardiovascular disease over the next 10 years for the patient. And it's recommended that it be assessed at each clinical visit to look for trends. It's available as an app. You can find it on the internet, and it is built into multiple electronic medical records. And in fact, it's built into the one that I use in my clinical practice. So it pops up for each of my patients at each visit. So it's a very common risk calculator. These are the items that are typically measured for this risk calculator. You can see that most of them are objectively measurable, like blood pressure, cholesterol, but some you have to ask the patient and they have no biological basis. For example, race. And I'm just going to take a little detour to remind us that race does not have a biological, is not a biological category. So a reminder that there's no fixed coherent definition of race. It's unstable over time and place. So the racial categories in the United States, for one, have changed over time. And myself, who is considered African American or Black in the United States, when I travel to other countries, I fit into different racial categories in those places, even though I'm the same person, obviously. It has no genetic basis or consistent traits. So racialized traits like skin tone and hair texture, cross-racial lines vary within the same race. It's not a proxy for ancestry. There has been no finding of consistent genes or genetic sequences in all people of one continent or country. And in fact, racialization itself is a social process that has some real significant impacts for people's health. And it's beyond my scope to dive into that, but I have on the right that I highly recommend a paper by Charmaine Royale in Nature Genetics in 2004 that really outlines the challenges with this idea of the biological basis of race. And also a book by Dorothy Roberts that looks at the implications of the creation of these racial categories politically in the United States. So back to that risk calculator. So I think that there is increasing common understanding about race being socially constructed, but very little about sex being socially constructed. Oh, I also wanted to say in the race category, you can see that your options for the calculator are white, African American, and other. And having looked at this equation itself, the back end of it, which is very painful, I don't recommend, it really is white and Black. Other is collapsed in white when you do the analysis using their algorithm. Then if we look at sex, we also have two options, male and female. And that is obviously complicated when you're providing care for transgender people. But I do want to remind us that sex and gender are both multidimensional. I think we are, if y'all are here at the talk, you know that gender is multidimensional, but we might forget that there are many layers to sex. There's chromosomes, gonadal sex, hormonal sex, internal reproductive organs, external genital sex organs, and we expect them all to align in a certain way because they do typically, and we categorize those as male and female to create binaries, but this is socially determined. And I would challenge that most of us have no idea what our chromosomal sex is, right? And we know that there's an SRY gene that determines what's turned on and what's turned off in terms of activation of those genes. And it's estimated that about 1.7% of the population has non-binary sex traits. And often gendered socialization begins at birth, and we attribute attributes that might be related to socialization to being biological sex traits. Again, I don't have time to dive into this, although I find it super fascinating. I recommend the work of Anne Fausto Sterling with one of her earlier papers in the Sciences in 1993 that first talked about this 1.7% of the population, but she's also published many other books, including Sexing the Body and Sex and Gender. And she's a retired biologist now from Brown University that has done all of her research in this area. So given that race is more complicated than the two categories we're given in the calculator, and sex is more complicated than the two categories that were given in the calculator, what does that mean for providing care for transgender patients? And our team has published two papers using data from the Light Plus study that I'm going to describe to you in just a moment. One of them in the American Journal of Preventive Medicine really looked at what happens specifically around the gender category, and then the health equity paper looked at race and gender. So I'm going to talk a little bit more about the race and gender classification in the health equity paper. So this is a Light Plus study. I know Jason's very familiar with it. The official name is at the top that NIH calls it, but we call it Light Plus for the participants, and because it builds, it's a sister cohort, I guess, to a cohort of transgender women who are not living with HIV. So this is a longitudinal study with Black and Latina transgender women who are living with HIV. The aims of the study overall are to look at relationships between intersectional stigma and chronic stress, and then chronic stress and comorbidities related to HIV, and pathways that might link stigma, stress, and gender-affirming hormones with HIV comorbidities, particularly mental health and cardiovascular disease. And obviously today I'll be talking about cardiovascular disease. The study design is to follow participants for 24 months, collecting baseline 1 year and inline surveys with shorter surveys at 6 and 18 months. We collected qualitative measures, blood work, clinical measures, and a salivary cortisol protocol that I'll describe a little bit later. There were 3 sites that collected data in DC, Boston, and New York, and 108 Black and Latina transgender women enrolled. We're going to just look at the baseline data for this particular analysis, and I'm going to jump right to the findings because I want to spend most of our time talking about allostatic load, because I'm sure you're like, allostatic load was the first word in your talk and you're talking about something else. So I'm going to get there. But I first want to trouble the waters around how we even measure cardiovascular disease risk. So in this analysis for the health equity paper, what we did is manipulated across 6 categories of race. So Black and white, all the participants that we included in this analysis were self-identified as Black, but we looked at what would happen if they hypothetically identified as white. And then we looked at categorizing them based on their sex assigned at birth, which was male for all participants, their current gender identity, which was female for all participants, and assigning them a female identity if they were currently on hormone therapy, right? Which is what sometimes people do when they're looking at these risk calculators. These are all things you can do using these risk calculators. And we also considered a risk of greater than 7.5 to be criteria for starting statin therapy, which is what was commonly recommended at the time. Before the Reprieve study came out, Jason. So these were the guidelines. And what we found, not surprisingly, is that if people were identified as white and female, then they had the lowest proportion were recommended for statin therapy, and assigned male at birth, and Black, highest proportion recommended for hormone therapy. But you can imagine a patient who appears white-skinned to a clinician and might even self-identify as white, but may have ancestry from Africa, which is what we assume of Black people, might be in this category and may or may not be somebody who should or could benefit from a statin. We also looked at the rate of reclassification if we moved people along their categories. And not surprisingly, based on what we just saw, the greatest rate of reclassification was moving from Black male to white female in terms of risk for cardiovascular disease greater than 7.5% and therefore being recommended for a statin. So hopefully that made sense. If it didn't, hold your questions, ask me at the end. I'll explain it better. You might be saying, well, in December, the American Heart Association recommended a new calculator, the Prevent Online Calculator, and it got rid of race. It added important other factors like a social deprivation index that is an option that you can include to consider that as part of cardiovascular disease risk. But what it didn't change is that there is still a requirement to include sex, and the options are still binary male or female. So it leaves many of us wondering, well, what should we put in for our transgender patients? And that is what we call out in the health equity paper. And this is a press release from the health equity paper that was really focused on clinical algorithms. And we got permission from them to not only look at race and clinical algorithms, but also sex/gender. And we know that there are structural factors that drive the racialized and gendered health inequities that we see, but our reliance on these calculators that use these social factors risk either over-prescribing or under-prescribing statins, and could potentially perpetuate clinical biases that affect treatment and ultimately reinforce or perpetuate existing population-level inequities. So what else can we do? I'm a big fan of Life Simple 7. One, because it has the word simple in it, so that's often exciting, right? But it focuses on modifiable risk factors. And while it's true, you can talk to your patients about all these things, you're like, well, what can I do for a calculator? There is actually a Life Simple 7 calculator that can give you a risk score based on modifiable risk factors. And you can see people move in their score based on how they may or may not change these modifiable risk factors. And you're probably all aware that there's Life Essential 8 now that takes into consideration sleep, which I think none of us get enough of, but that's a topic for another day. So in summary, in terms of the assessing part of addressing and assessing cardiovascular disease risk, a reminder that race and gender categories are multidimensional, dynamic, socially constructed, not based on biological or clinical measures, and reliance on them can perpetuate existing population level inequities, and that we could benefit from using frameworks like the Life's Essential 7 or 8 to initiate these conversations in the context of holistic health parameters that can be modifiable. So I was told not to pause here for conversation, that we'll have all our conversation at the end. So I'm going to jump into the second part of the talk, which is really the addressing part. And we're going to dive into the allostatic load information here. So just as background, why are we talking about cardiovascular disease, particularly in transgender women? A European study that had 50 years of longitudinal data on transgender and cisgender people found that cardiovascular disease risk mortality was 2.5 times higher for trans women compared to cis women in this cohort. We know that trans women have higher rates of both traditional and non-traditional risk factors for cardiovascular disease, high prevalence of living with HIV, which is associated with greater cardiovascular disease risk, exposure to psychosocial stressors like transphobia, and estrogen-based gender-affirming hormones. But when I went to apply for this grant and then prepare this talk, I found that most biomedical research examines only estrogen as the reason for cardiovascular disease risk among transgender women. So there is like almost a singular focus on that particular risk factor. But if you go back to the 2021 statement from the American Heart Association, you can see that's much more complicated than that, right? They walk us through all these microsystem and macrosystem factors. They talk about psychosocial factors, behavioral factors, clinical factors, psychosocial stressors, physiological stressors, and how all of those can lead to cardiovascular disease events. So if we focus in on mechanisms and look in particular at microsystem and macrosystem events, this is the best I could do to summarize like literally a 5-hour talk I could give on social and structural inequities faced by transgender people. We start in the upper right. We know in 2024 alone, if you've ever turned on the news, you know that there is an enormous wave of anti-transgender legislation sweeping the country. And this year alone, 661 bills have been proposed across 43 states, all attempting to restrict access to healthcare, education, legal recognition, public restrooms, participation in sports across many specters of life. Not surprisingly, with this level of increased visibility and hostility, hate crimes against transgender people are spiking. And even before the transgender bills started exploding across the US, there were the data that we have at the bottom here, which were from, I think, 2018. We know that there's higher rates of unemployment and poverty in trans communities because of stigma discrimination, housing discrimination, and homelessness is high. People experience bullying in school and often have an incomplete education related to that. Higher rates of food insecurity, not surprisingly, if you're experiencing employment and housing discrimination. Young trans people experience higher rates of being kicked out of their home with little family support. And unfortunately, healthcare isn't a safe haven. So sometimes people are unable to access both gender-affirming care and primary care and often delay care due to concerns about discrimination. So this is the social and structural context of the lives of trans people in the United States right now that can definitely impact their cardiovascular disease risk. And so it's pretty easy to imagine how this might affect psychological stress. Obviously, hearing in the news every day negative things about transgender people is hard on the psyche. But what has underexplored is what are the physiologic stress responses that could be related to this experience. This is a modification of something that's called the minority stress model. The minority stress model itself was first developed by Virginia Brooks in 1981. It was modified by Elin Meyer in 1993 and really has been taken up across health inequity research related to sexual and gender minority populations. So we have modified it here to add the focus on allostatic load. But In general, what minority stress models do is they describe the stress that everybody experiences in the environment and how that leads to general stressors. And then the particular stressors, and this is transgender women living with HIV, that minoritized populations experience related to prejudice, discrimination, violence, and then those proximal stressors that are related to internalizing those experiences, expecting rejection, needing to conceal one's identity for safety, things like that. It also talks about resilience and coping, but we're not going to talk about that today, sadly. But I will talk about it tomorrow at the branch talk if you want to come to that. What I want to focus on here is how do these experiences become embodied? How do they get under our skin, as we might say? And that is through a process that we propose called allostasis or allostatic load. So allostasis is a normal physiologic process where we're exposed to stress. We have a physiological reaction to that stress, and then we recover. And that is a normal process of adaptation. We all experience stress, and hopefully we all recover. But what happens when one experiences chronic, constant, repeated, stressful experiences? If every day you leave your house, you're harassed for being trans, if every time you turn on the news, you're hearing negative things about trans people and you're a trans person, it can lead to all kinds of dysregulation, lack of that adaptation that is a normal response. It could lead to prolonged elevated activation of the HPA axis. It could lead to suppression of that axis and inadequate responses. And all of those things are dysregulations that can lead to physical and mental health problems. So hopefully you followed me there, because that's the basis of everything we're going to talk about. Okay, thank you for nodding, Jason. All right. We collected way too much data for this study. It was like, never again will I subject people to collecting this much information. But I have some of the key constructs highlighted here. We obviously measured perceptions of stress, and I'll go into detail about these later. We collected data on gender-affirming interventions, including medications that we drew both from patient self-report and medical records. We collected clinical measures and biomarker data that I'll also talk about in more detail in a minute. And we collected salivary cortisol. I was super excited about this part of the study. I will say it was the hardest part to do. So only about half of the participants agreed to do this part. So you'll see later that the sample size for this is smaller. And I went to spit camp to learn how to do it, and I have a PhD, and it was difficult, let me tell you. So as soon as you wake up, before you put your feet on the floor, you drool into a little cup. 30 minutes later, before you brush your teeth or anything else, you drool again. And then before you go to bed, you drool again. And we use that to create the diurnal curve of salivary cortisol. We also have a fantastic student who's collecting qualitative interviews, and I'm not going to be able to share that with you today, but it was really important to us to also include the voices of the participants and their own experiences. So we're going to focus on the ways that we measured stress. There was a self-reported perceived stress scale. It's a 10-item scale that's been validated in trans populations. Higher scores on this scale are associated with more self-reported stress. An example of the kinds of questions that ask is, in the last month, how often have you felt nervous or stressed? I just described how we collected data on the cortisol, salivary cortisol diurnal curve, and we measured we used two measures in our models, the cortisol awakening response and the cortisol daily decline. So the cortisol awakening response is that first peak that you see between when someone wakes and 30 minutes later. There should be a pretty sharp rise as your body goes, whoa, I'm waking up. And there should be a spike in the cortisol then. And then we should see a decline over the course of the day back to the lowest level as we get ready for bed. We know that dysregulation from chronic stress means that this peak is lower, so a blunting of the cortisol awakening response, and also a blunting of the daily decline where it doesn't fall back down. And then finally, the allostatic load was measured using 14 biomarkers, in which higher scores were related to greater stress-related physiologic dysregulation. A little more about the allostatic load index. I will say that we partnered with Rob Paul Juster, who is a Canadian researcher who studied under McEwen, who was sort of the, I don't know, hopefully he's not on this call, a grandfather of allostatic load measurements. But the calculations are based on those recommendations. You can see that it's a pretty straightforward calculation. For any abnormal laboratory result, the person got a 1, any normal laboratory result, they got a 0, and then we add it up to get the score. If they were on medications to treat one of these conditions, even if the lab result was normal, so for example, their A1C was normal, but they were on a diabetes medication, they still got a 1 because we know that their systems are dysregulated from having diabetes. You can see at the bottom right, the allostatic load index distribution for the study sample. So I will say that most previous studies, people cluster around 1 or 2, and you can see we had a much wider distribution in our study sample. And this isn't anybody's real result. This is just an example of how it's calculated. So let's dive into the data. Of the 108 Black and Latino transgender women that participated, the average age was 40. The interquartile range was 34 to 52. Obviously, they were Black and Hispanic because those were the people that we enrolled. What I want to highlight is the kind of experiences, the structural challenges that our participants were facing. So you can see that 56% had a high school diploma or less. Income below the poverty level was experienced by almost 53% of the participants. 69% had ever been homeless. The average days when people could not find a safe place to sleep was 4.9. Rates of material hardship were high, and rates of food insecurity were high. So this is the study population and what they had experienced. Similar to other studies, most other participants had taken gender-affirming hormones at some point in their lives. About 80% were currently taking at the time of baseline data collection. The number of months that people had been on estrogen-based gender-affirming hormone therapy was 60 months, so about 5 years. And you can see there's a wide range in the number of years, months and years people had been taking hormone therapy. We have the average of the stress measures here with the perceived stress score being sort of in the middle, allostatic load being about 3, and then the cortisol awakening and cortisol daily decline results. And then the overall cardiovascular risk score was 3.25% as the mean using the pool cohort equation that I already problematized for you. And we used, for the sex variable, we used sex assigned at birth for this analysis to be consistent with the Reprieve study, which included transgender participants. It was a large study of people living with HIV and cardiovascular health. Included a little over 100 transgender people and used the sex assigned at birth for those participants too. So our research question related to this, we know that gender-affirming hormone therapy duration, the longer someone takes estrogen-based gender-affirming hormone therapy, the greater their cardiovascular disease risk. And we saw this in our data. So what we wanted to know, does chronic stress moderate this relationship between duration of gender-affirming hormone therapy and cardiovascular disease risk? What we found in our multivariable model, when we look at the cortisol response, you can see the graphs here and our modeling. Sorry, you can't see my little mouse moving, can you? You can? Yay! Okay. So what you can see on the right are the graphs that I'll describe to you in a minute, and the model here. In the model, you can see we controlled for age, income, and education. And then we looked at the relationship between hormone duration and cortisol awakening response, and hormone duration and cortisol daily decline in 2 separate models. So this is one model, this is the other model. And the important parts about the finding is that hormone duration was no longer significantly associated with cardiovascular disease risk in these multivariable models. And you can see that neither was cortisol daily decline or cortisol awakening response. And when we looked at the extremes, because one of the things I had questions about is there a ceiling response? Is there a certain amount of stress you have to experience before it has an effect on the relationship between gender-affirming hormone therapy and cardiovascular disease risk? So we looked at the highest and then at the lowest. So you can see for cortisol daily decline, let's see right here, when the CDD is at its highest, or the worst, cardiovascular disease risk increases with the longer use of hormone therapy. Where's my arrow? Here. And when it's at its lowest, it decreases, right? This is not statistically significant. You can see the confidence intervals completely overlap here. And then for cortisol awakening response, they were just basically on top of each other. But the trend is for worse dysregulation to be associated with increased risk. For these models, we looked at perceived stress and allostatic load. These were two separate models. And you can see again, hormone duration is not statistically significant. Allostatic load was statistically significantly related, even though hormone duration was not. And when we looked at this graph here, you can see there's no overlap in the confidence interval. When allostatic load is at its highest, cardiovascular disease risk increases with longer use of gender-affirming hormone therapy. And when it's at its lowest, it doesn't change with longer use of hormone therapy. So the take-home message from all of that, which I flew through, is that allostatic load was significantly associated with cardiovascular disease risk in models that adjusted for age, income, and education, but gender-affirming hormone therapy duration was not. It only increased risk among participants with the highest allostatic load. Some of the physiological changes that increase cardiovascular disease risk among transgender women may be due to chronic stress exposure rather than hormone therapy alone. And this is not something that I'm familiar with clinicians talking to their patients about. I'm familiar with people talking about the risk of hormone therapy, but not how that risk may change depending on someone's exposure to chronic stress. And reducing chronic stress that transgender women bear can be an important way to reduce cardiovascular disease risk. So I cannot end a talk without calling for more research as a researcher. So we need to look at intervenable factors, including things that reduce stress beyond gender-affirming hormone therapy. And we as clinicians have an opportunity to reduce stress in the settings where we work. There's obviously things we can do politically, write op-ed, share factual information, things like that. But also, there are a number of points of access in healthcare systems where we have the opportunity to change a patient's experience and create a welcoming environment. From how we talk to people on the phone. And I can't tell you how many times I've received like a inbox message about a patient that called, and that patient was misgendered because of the way that they sounded on the phone by the person who took the message. So just training people on how to use gender neutral ways of communicating with patients on the phone, having forms that allow people to say who they really are, providing options for people to identify as trans if they wish, for using chosen names and pronouns on those forms so people know how to properly address them. Having signs in the waiting room, just a patient bill of rights, material that's appropriate for trans people, indicating that you are aware that trans people exist. Our staff started wearing pronoun buttons, and it's really made a huge difference in how trans patients interact with us and assumptions they make about how welcome they are in our clinical space. Having all gender or gender neutral bathrooms available, having people speak appropriately to people when they bring them back to the room and not make assumptions when they're calling people from the waiting room about whether to use Mr. or Ms., but some gender neutral way of calling patients back. When you're doing the history and physical exam, I have a whole talk on this too, just how to ask questions in a gender neutral way, how to not make assumptions about what body parts people have, how to do an anatomical inventory so that before you do an exam, you are aware of what to expect and don't experience surprises. And then when you're writing in the medical record, how we write about a patient's identity is really important, especially with the 20th century CARES Act, I think it's called. Patients have access to everything that we write in their medical records. So you can be a wonderful and great clinician and have a good rapport with the patient in person. And there's a beautiful paper by Ash Alpert that talks about this. Then when patients look at their chart, if they see that they've been misgendered in their chart, or have like parentheses around their gender or other ways of indicating or invalidating their identities, that can really destroy a relationship and be a very stressful experience for patients as well. So we have lots and lots of opportunities in our clinical setting to provide an affirming and stress reducing environment for our patients. So That went a lot faster than I thought. I think I just talk fast, so I'm happy to go back to anything when it's time to for the question and answer section. Um, I do want to acknowledge that it always takes a village to do things like this. So these are the statisticians, some of the co-investigators. This is Rob Paul, our allostatic load expert, and Zachary Dubois is our cortisol expert, and then a sea of lovely people who made this happen. And of course, none of that would be possible without the study participants um, who agreed to spend a really long time with us during a pandemic and allow us to collect such extensive data. So thank you all for showing up and for listening. And I'm happy to answer any questions or go back to anything that I went through too quickly.
Thank you so much, Dr. Poteat. And just to let you know, Jason also had to skedaddle away because he has one more patient to see. So I will be supporting the post-lecture conversation. I think he'll join us shortly. I see that we have several on camera, and I wonder if we want to have any questions from the group as I collate some of the other questions that are coming in by chat and text. Dr. Branch? It looks like you might be. Okay, sorry. Didn't mean to put you on the spot. Okay. Dr. Collins, please go ahead and unmute.
I can't hear you.
Yeah, I have a question. This is Dr. Branch.
Oh.
Is there a more convenient way to measure stress than cortisol levels? I mean, for example, I have a vague recollection of people using skin conductivity as a way of measuring how much stress someone is under. I'm asking that because I'm thinking it would be good to measure the stress in circumstances. I mean, one of my interests is in communication, simply having someone listen carefully, express empathy, be respectful. Those things can be measured or at least coded on a video if there were a way to determine whether stress goes down when you have a provider that's able to really use communication skills to connect with the patient.
Yeah, I think there's a whole literature on that. I'm not super familiar with it, but I can share that I have seen some people use heart rate variability as sort of a in the moment stress measure. I think the challenge for us is that we wanted to look at cumulative stress, like what is the wear and tear over the life of course of the person and how is that embodied? And that is, I think, more complicated. But I have seen people use those things like heart rate variability to look at like in the moment stressful responses. Thank you for that question. And I love that you're doing that like empathy work. So important.
I think that it would be interesting to study the transgender population as a population that's under a lot of stress, to see to what extent doctor or provider interventions can influence that. I'd be very interested because I've always believed that, in fact, that it does have an influence. It goes beyond just the time you're with the patient.
Thank you, Dr. Branch. And similarly, Dr. Poteat, if you wouldn't mind, Dr. Haw in this chat also had a similar question. So not like Dr. Branch talking about other measures, but more, is there any research that's been done on ways to reduce allostatic load besides prevention? And is there anything that shows some promise?
Yeah, that it's a early in the field of allostatic load research. Honestly, longitudinal studies are still relatively rare. And I think this is maybe the fourth study with transgender people. So I haven't seen a lot of intervention research like once somebody has this chronic wear and tear. I would imagine this is not research, but I would imagine the more stress reducing experiences people have. I know that there are people at Emory and at other places that are looking at mindfulness-based stress reduction interventions, and those hold a lot of promise. I have a colleague in Canada who's looking at, I wouldn't call it art therapy because she's not a therapist, but self-expression, artistic expression as a way of sort of calming the, nervous system. And I think those interventions all hold promise. I haven't seen like clinical trials looking at outcomes in transgender patients. So lots of opportunity.
Great, thank you. And I think Caroline Collins worked to improve her audio, but that was actually her question also. So thank you for speaking on that. Another question in the chat. Thank you so much for this talk. Our PA students regularly inquire about differences in ASCV calculations in the transgender population. And I think, the question is really how can we I think we've been excited about the PREVENT calculator and its acknowledgement about race, not as a biologic construct, but much more, and using components to much more get at what race was prior being used as a proxy for. Do you know if there's any conversations about this next phase? It looks like from what I understand, it took the PREVENT group somewhere around 7 years to get to where they are now. And is there a next phase that's being planned that can be more inclusive of our transgender populations?
That is a great question. And the best I've been able to find is I'm one of those people who lurks on NIH Reporter. So I lurk on NIH Reporter to see who's doing trans health research. And there is somebody who is proposing to do a longitudinal, I'm pretty sure it's a longitudinal study looking at how to best encapsulate whatever we mean by sex and gender in those calculators. So hopefully in a few years, we'll have some results from that person. I didn't know them, so I couldn't really stalk them or maybe cold email.
But that is promising to know that work is the foundation for that work at the very least is being laid.
Yes.
Vintang Precha, another similar cohort type question. Again, thank you for highlighting the cardiovascular risk in this population. They've been doing the AHA Life Essential 8 in their clinics, and he says, no surprise that the scores are low. What is the appropriate control group as opposed to the average American for transgender and gender diverse people?
Control group for, I'm sorry, maybe I'm confused.
I want to make sure that I'm not misstating. Vin, can you clarify?
So, as Karen said, the scores are low. So we're trying to see, is there something besides the hormones contributing to the cardiovascular risk? So is there another population that we should compare our scores to, or just there's other factors besides hormones causing the cardiovascular risk? Guess it's a little bit complicated question.
Yeah. And I'm still not sure I understand it, but I'll do my best to answer and you can tell me if I'm getting it all wrong. Yeah, I think it depends. This is students hate it when I say this, but like it depends on your question, right? Like in the clinical setting, I would say I just want people to have the best scores possible available to them. So I think compare them to themselves over time. So that would be my answer on a clinical practice scale. In terms of a research scale, I think that is not an outstanding question, like great, but like question that is still people are talking about, right? Like if we're looking at scores among transgender women, do we compare them to cisgender women? Do we compare them to cisgender men because of their sex assigned at birth? Like, what do we do? And I don't think that people know for sure. And what I've seen people do is both. And I think we just reviewed the same paper that we gave that feedback to.
Yeah. I think that answers my question. I think we don't really know.
Yeah, we don't really know.
Thank you. Caroline, I'm going to call on you again.
Thank you. So Tonia, I'm interested to hear about any interventions that you might plan on doing in this cohort of patients that have gone through this study already to see if there's anything that you could intervene on. And then my second question is, it sounds like you did a lot of this research during COVID when stress may have been at its peak for a lot of people. Was there any thought of that playing a role in your data?
Yes. Woo, was there a lot of thought? So we began data collection about in October of 2020. So guess what happened in December? Like everything shut down, nothing happened for a year. And then we had enrolled maybe 30 people. So then we had to stop. And then we just re-baselined everybody. There was just literally no way that we could longitudinally follow somebody with a pandemic in the middle and then think we could compare them to other people. So you're absolutely right. And it is true that it could be that the levels were higher. We just had a paper accepted looking at our pre and post data. So hopefully that will be out soon. We did see rises in allostatic load from pre and post COVID writ large. But given that everybody was, after the onset of the COVID pandemic and we were comparing within the population, I think the findings still hold. But it was really sad day to have started data collection. And then, it was a really sad day for a variety of reasons, right? But it definitely had a huge impact. And then in terms of interventions, I'm glad you asked that because we've been thinking a lot as a study team about what our next steps are, partly because we just love the participants. You follow people for 2 years, you develop these relationships with them. They're all amazing. And then you get the results and you're like, oh, what can we do? So we were we've been looking for pilot funding to look at applying this mindfulness-based stress reduction intervention with our study participants. So if you have suggestions for pilot funding, that would be awesome. But that's where we are right now, and totally open to things that have been successful in other populations and trying to see if they work for this population as well.
Thank you, Tonia. And we're going to welcome Jason back.
Hi, Jason.
All right, just step away. Thank you for sharing your work with us. I have a more general question. We have a lot of trainees in the audience, of course, faculty, and they may be thinking to them. Some of them may be thinking to themselves, "Well, this is a talk about transgender people, and I don't have any transgender people in my clinical practice, or I don't regularly interact with transgender people. So why do I need to be concerned about this?" I haven't answered that question. So I'm interested to hear how you answer questions when they're posed to you like that, questions like that. And then once answering that question for us, how do you think our work, yours and my work with this population, people with this community, helps us think about the care of other minoritized populations?
Yeah, you know how I'm going to answer because you've known me for a long time. So my first answer is always like, how do you know that you don't have any transgender patients? So if you're not asking, you don't know. And often if you are asking, if people don't feel safe, then they're not going to tell you. So I wouldn't make an assumption that people don't have transgender patients. And the second is that the questions around the risk calculators are especially salient beyond transgender people because we don't know what that sex variable is supposed to mean. So is a cisgender woman who's had menopause and maybe is not taking hormone replacement, is her, what are we saying by putting F for her in the same way that we put F for a cisgender woman on birth control pills or a cisgender woman who's not in menopause? Like there's many ways that hormone fluctuations change in the life of cis and trans women. And we don't know what that F variable is trying to capture. Is it trying to capture that hormone? Is there something genetic that it's trying to capture? So if somebody is intersex or has intersex traits or differences of sex development, what aspect of their sex biology is supposed to be captured by that? And how would we need to adjust that in the risk calculator? So I think it has broad applications in terms of measurement. And then, for other minoritized populations in terms of allostatic load, there's been much more research around race and allostatic load than there has been around gender and allostatic load. And it's a little more complex than we think. Like often if we look at these I remember I read one paper about young Latino boys in school, and the higher performing they were in school, the higher their allostatic load. So there was a cost to performing or overperforming in a stressful setting, right? Where you experience stigma, discrimination, you're working hard to overcome, and then your body pays the price. So I think that there's a lot we still have to learn about the nuances of allostatic load, and definitely across any marginalized or minoritized population. So it was a long answer to your question. I'm not even sure I answered it. So, you know.
Transgender people are everywhere, and I think this, when I think about my own work with this community, it really is been instructive in thinking beyond the binary and categorizing people when it's arbitrary and likely unnecessary, and as you've illustrated for us, potentially harmful.
If I may, I'd love to piggyback on Jason's question to ask Colleen Kelly's wonderful question, which I think would be very useful as we all think about becoming, adapting our patient questionnaires to be as inclusive as possible. It'd be really helpful for us to hear from you some clinical pearls on organ inventories and gender inclusive language in a clinical setting, because scripting is always so helpful for us.
Oh, let me whip out my talk that I No, I won't subject you to more slides. So I can talk about what I think we do well and don't do well at our practice, and what I think I do well and could do better at in our practice. I work in an infectious diseases clinic, so I will say that. But one of the benefits I think of our clinic is that we're housed in a building and on a floor with multiple other practices. So nobody's knows that you're coming to see the infectious diseases people unless you tell them, because we're also the cardiovascular floor and the same day clinic and internal medicine. So, depending on how out somebody is about their gender identity, having a trans specific practice can be fantastic because they know where to go get care, and hopefully they'll be treated well there. And it could also be a deterrent for some people who might not want other people to know that they're trans. So I will say that. I try to introduce myself, but just my name and my pronouns to start off. Like, hi, I'm Tonia Poteat. My pronouns are she and her. How would you like for me to refer to you? And it's low stress. If they look at me like, what do you mean by pronoun? Then I just explain, she, her, he, him, blah, blah, blah. And I do that. I try to do that with every single person, not just people that I think are trans, right? So you're level setting for everyone. And I've started charting. Instead of putting like 25-year-old male, I will put 25-year-old adult. And then in parentheses, I'll put what pronouns they go by. Because unless I think there's something about them being assigned male that is important to their care, beyond whatever I'm going to put in their physical exam, then it doesn't need to be in their introduction. What else do I do? So yes, organ inventory is something that we typically, some places ask the patient to fill out, but I'm sure you've all had the experience where you've talked to a patient who's had a surgery and they're like, I don't know how many people I've talked to who don't know whether or not they have a cervix. And I'm like, well, I guess we'll find out today whether they have a cervix. But those can be really helpful. Just asking, we have an Epic, we use Epic, and we have an Epic, I don't know what you call those, form that asks what organs was the person, did the person have at birth? What were they expected to develop based on their sex assigned at birth? And what organs do they have now? And that can be really helpful because often when we say someone's sex assigned at birth is this, it often means that we're making assumptions about what their anatomy is now. And we don't know that. And sometimes asking about surgery isn't the easiest way to get that information, or even the most accurate way to get that information, given that there's variability in sex traits that people are born with. So that's what I can also send it a screenshot of our Epic, because I stick it in presentations all the time, because I think it's really handy to ask that. And also just ask it of every patient. Like we go through this with every patient. It's part of the history and physical exam. That was a lot of talking. I don't know if that answered your question.
Very much so. Thank you so much. Caroline, I see your hand is raised.
I'm not dominating the conversation, but I had another question around really what we put in the chart, especially referring to our transgender patients and other communities. I find that in AI software, especially with software we're currently using to help us write our notes, I find it makes assumptions about someone's gender or gender identity, and frequently patients will make comments about that, and sometimes it uses pronouns they them, or she her he him, incorrectly, and I have to go in and correct it, and sometimes you may miss some. So how have you encountered AI, and do you have any tips for how we might go about talking to our patients about that and what's in the chart?
Oh, thank you for raising that as like one of my pet peeves, right? Like it pre-populates based on some other part of the chart that I don't even know where they're getting it from. So I've created my own dot phrases that I try to use instead of whatever Epic gives me. It's a pain in the butt. But I do that sometimes. And I also do what you do, like painstakingly try to go through and replace where they've gotten it wrong. But it is a problem. And I think we can go to the developers, honestly, because this is the 21st century. And if you can make AI, you can get it to give the right pronouns. So starting at the source is probably going to be the most effective way to do it, because it's a lot of extra work on the clinician. And sometimes it can help, depending on your rapport with the patient, just to tell them like some of these things are auto-populated. You might say things in your chart. If you do, let me know and I'll go correct it, because we can go do that. And that might be a way to build stronger rapport with your patient, because they know that you're thinking about that.
And then separately, since, all of these AI, we're all learning how as we go with these AI tools, and some of these are generative. I wonder, and I will try next time when I'm using a bridge to say out loud, I am seeing this patient and their pronouns are Bob, and just see if that changes the accuracy of the note throughout. Yeah.
Let me know. That sounds like a whole other thing that could be studied.
I think we're all sort of learning how to train the AI to do what we want it to do with mixed results.
Yes. Oh.
Well, we are just turning at 1 minute away from the hour, and this has been such a wonderful presentation and important discussion. And we feel so grateful that you were able to join us today, and will continue to share your knowledge and expertise and conversation with us over the course of your visit. Jason, anything to add?
It's not too late to sign up for tomorrow evening. Sonia Green has put information in the chat there. So yeah, please join us over at the School of Medicine.
Thank you all for having me. It's really been a pleasure talking with you all. I really enjoy it.
Thank you, Dr. Poteat.
Thank you so much. Everyone have a great day.
Thank you.